Rakesh, can you say something about yourself and uh, Rakesh? Rakesh, are you here? You need to unmute yourself, Rakesh.
Good evening, all of you. First, I would like to thank Professor Allen for giving me such an opportunity. So, I work in the eastern part of Nepal. So, it's a university hospital. So, I am the one of the consultant in the minimal invasive unit and general surgery in my hospital, and it's near about 1,000 bedded hospital. And Professor Allen has visited us twice in my university, and that's it from me, Prof.
Thank you, Rakesh. Before we start, I would like to call on the three chairmen from the three different centers. Let's start off with Dr. Ray Sarmiento. Dr. Ray Sarmiento is a surgical endoscopist. He's the chairman of Rizal Medical. Ray, to welcome everyone. Unmute yourself, Ray. Nakamute ka pa rin, kuya.
Hello. Yeah.
Perfect.
Good evening, everyone. Thank you for joining us. Thank you, Dr. Benefe, for making this teleconference possible. And I hope tonight will be another webinar that will be very useful and fruitful for everybody. So I will not say much so that we don't eat up the time. Thank you very much.
Thank you, Ray. Can we call on also on Dr. Alex Palines? Dr. Palines is the chairman of Batangas Medical Center.
Hi, good evening, everyone, and welcome to our fifth webinar. I would like to take this opportunity to thank our foreign guest, Dr. Rakesh Gupta. Welcome, and again, I'm sure this will be a very informative webinar session. Thank you.
Is Dr. Abari here already? Dr. Abari is the chairman of Quirino Medical Center. Dr. Abari.
Sir, hindi po nakakonect si Dr. Abri, sir.
Can we call on Dr. Joel Silahe? Dr. Joel Silahe, training officer and the MIS head also of Quirino.
Thank you, sir. Good evening to everyone. And again, thank you to our foreign speakers. I'm sure this is going to be educational for all of us. And also, I'd like to express gratitude to Dr. Alan Benefe for making this possible, and also for extending the invitation to the residents and staff of Amang Rodriguez Memorial Medical Center, and also to Fatima University Medical Center. And I would like also to acknowledge the presence. The chairman of Amang Rodriguez is here. Si Dr. Ramon Badillo po is present. Thank you very much, sir.
Hello, Dr. Badillo. Hello po. Welcome po. Included actually in this conference, this is our weekly conference for the UMIST group, we invited also SPMC, which is the biggest hospital in Davao, actually in the Philippines, biggest training center in that part of the country, in Mindanao. We also invited JBL, so we have participants. I can see Dr. Noel Evangelista, Paulino Garcia, Fatima, and Amang Rodriguez. Anyway, we have two fellows. Our weekly conference would always be presentation of fellows, and we invited several foreign speakers to add on to the lectures of the fellows. Anyway, this is a basic conference for the fellows. The first lecture will be from, who's the first lecture? Arlene is the moderator, right?
Si Sir Alex po, sir.
Okay, Alex.
Okay, good evening, everyone. For our first presentation, we call in Dr. Charlie Main Kabangal to talk to us about abdominal access and principles of laparoscopic port position and ergonomics. Charlie?
Yes, sir. Can you see my slides, sir?
Yep.
Okay.
Go ahead, Charlie.
Okay, good evening, everyone. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala, and a pleasant evening, everyone. I would also like to acknowledge that we have also consultants and residents from Zamboanga City Medical Center who are present today and listening to our lectures. So good evening. My name is Dr. Charlie Min Kabangal, a fellow in training in the medical minimally invasive surgery. So this is our 5th weekly lecture. We will be discussing abdominal access, principles of port positioning and ergonomics, and I will also continue to discuss some of the instrumentations that we have failed to discuss during our previous conferences. So as a disclosure, I have no disclosure for this presentation, and I would also like to emphasize that this representation is not an expert on this topic, but rather a seeker of knowledge on this aspect. So for abdominal access, so this pertains to the technique upon first entry towards the human body by creating the pneumoperitoneum with a telescope or an instrument. So as we all know, there are two types of technique for abdominal access, the closed technique and the open technique. When we say closed technique, it uses a Veress needle to induce pneumoperitoneum, while an open technique would pertain to use of trocars and cannulas. As we all know, access to the abdomen would require a good or a sound knowledge on the anatomy, since about 20% of complications, mostly vascular injury and bowel injury, are caused at this initial access. So for the closed access is creation of pneumoperitoneum by inserting a Veress needle. This is a blind technique that we use on a preformed cavity like an abdomen. So there are two types of Veress needle. We have the disposable and the reusable types. So the needle is equipped, it was invented initially by a chest physician for aspiration of pleural effusion. It has a spring-loaded blunt stylet tip that engage as it entered the peritoneal cavity to prevent injury of hollow viscous. So for our closed access, usually it is placed with a 2 millimeter infraumbilical incision, and then a Veress needle would be held like a dart. And as the Veress needle is inserted towards the abdominal cavity, the abdominal wall is lifted to prevent injury to important structures. So the safety of using the Veress needle depends on, firstly, on the needle itself with its safety mechanism, as well as the technique of the surgeon by lifting the abdominal wall and directing the insertion of the needle towards a safer area. So there are different ways to determine if we have successfully inserted the needle towards the abdominal cavity without injury to other structures. First is the double click test, or the a double give or a pop test, wherein the first click would tell you that the needle has penetrated the rectus sheath, and the second click would tell you that we have penetrated the peritoneum. Another indicator is the needle movement test. So once inside the abdomen or the abdominal cavity, the tip of the Veress needle should be free, but this should be done gently to avoid injury to underlying bowels. And then we also have the irrigation test and aspiration test, wherein we inject 5 to 10 cc of normal saline. Ideally, it should be free flowing with no resistance on irrigation, and there should be no aspirate when we do aspiration. And next is the hanging drop saline test, or where a drop of saline is placed on the tip of on the hub of the Veress needle. And when we lift the abdomen, it would induce a negative pressure within the abdominal cavity, sucking the drop of saline from the tip of the Veress needle. And then lastly is we have the insufflation of gas test, or the quadromanometric test, wherein we use the monitor to uh, we use the insufflator to monitor the success of the insertion of the needle. So we have the preset insufflation pressure at 12 mmHg, and then the gas flow rate and the volume of gas that was consumed, as well as the actual pressure. So the gas flow rate should be at least 1 to 2.5 liters per minute. So if you have a flow of greater than that, it would give you an idea that it could possibly have a leak on the insertion. And for the gas consumed, or the volume of gas consumed, an average abdomen would consume about 1.5 liter, and a person with a bigger abdominal cavity would at least have 3 liters of would consume 3 liters of carbon dioxide. So normally it would take about 1.5 to 6 liters to attain a pressure of 12 mmHg. So if we have a lesser, if you're consuming less gas, it could mean that the placement of the tube of the needle is on the subcutaneous area. Or if we have more gas that was consumed, it could mean a leak into towards the external area. So once the peritoneum is created, we may proceed with the placement of the primary trocars. Usually it's placed on the same site as the Veress needle entry. And the initial 1 to 2 millimeter stub puncture of the skin would be extended to 11 millimeter to accommodate the primary trocars. The second type of abdominal access is the open type, or the open access. It uses the mini laparotomy approach by direct visualization of the layers of the abdomen as we penetrate towards the cavity. So there are two types of open access: the Hasson technique, which is midline incision inferior to the umbilicus, and the Fielding or the Scandinavian technique, which uses the umbilical pit itself for the incision site. So the safety of the trocar incision is based on the proper grip and insertion technique. So it would utilize a wrist control, which means that the strength or the control is placed on the hand and the upper arms rather than the body, using the body as weight in pushing the trocar. And the second is the finger brake, which means that we should have a good grip of the handle of the trocars, holding it like a pistol and using our index finger to serve as a finger brake to prevent unnecessary injury. And then the direct visualization of the abdominal wall layers, which would give us a further safety upon entry towards the abdomen. So this, coupled with the blunted tip of the trocar, would prevent inadvertent injury to the underlying structures. So the Hasson's technique was developed by Dr. Harriet Hasson in 1974. It uses direct open visualization, and the incision usually is in the infraumbilical area, and it uses a stay suture to hold the edges of the fascia in place. And then upon opening of the fascia, a finger is usually inserted to check for adhesions and release soft adhesions. And then it utilizes a trocar, a specialized trocar called the Hasson trocar, that has an olive or a cone that would seal the port, and has a blunted tip that would prevent injury. And the Fielding technique, on the other hand, was developed by Fielding in 1992. It utilizes a smaller incision compared to the Hasson technique. It uses 10 millimeter incision placed on the apex of the umbilicus and then directed caudally. So this would be the thinnest part of the abdominal wall. So there would be lesser trauma upon insertion of the needle, upon insertion of the trocar. And it uses a blunt conical tip internal trocar to to facilitate entry towards the abdominal cavity. So nowadays we have different types of trocars available. We have the disposable and the reusable types. We also have different types of trocar tips. We have some cutting trocar with retractable blades and non-bladed cutting trocars, as well as the blunt tip trocars. Moreover, we also have optical trocars, or the so-called visually guided entry. So this technique or this technology uses cannula with a 0-degree telescope to allow direct visualization of entry towards the abdomen. So, and also optical trocars are trocars that are transparent, that would allow us to see as we penetrate towards the abdominal cavity. And another concept is another concept of visually guided trocars are the Termanian screw tip optical trocar. This is a reusable cannula system wherein it is equipped with a clockwise rotating blunt screw tip that would technically uses lesser trauma and smaller incision upon entering the abdominal cavity. And we also have modification or upgrades on the Veres needle, wherein we have a Veres needle with built-in fiber optic telescope. So you won't be blind on entering the abdominal cavity with this technique. However, the scope is not as good quality compared to the scope of a 10 millimeter or 10 millimeter scope that we use with the trocars. So as we all know, there are contraindications for umbilical entry. Number one is previous midline incision, patient who have possible incision on the anterior abdominal wall or possible adhesions in the anterior abdominal wall that would render access difficult. Secondly, are patients with portal hypertension with recanalized umbilical artery due to liver cirrhosis. And then thirdly, are patients with abnormal umbilical abnormalities, such as those who have urachal cyst, umbilical sinus, and umbilical hernia, which would make access towards the umbilicus difficult. So with these cases, we can utilize the Palmer's technique in inducing pneumoperitoneum. So the Palmer's point is located at 3 cm below the left subcostal margin at the mid-clavicular line. So this is a relatively safe site or point of insertion for our Veres needle and induced pneumoperitoneum. And in some cases, or patients who are high risk with compromised cardiorespiratory functions and cannot tolerate pneumoperitoneum, there is also what we call the gasless laparoscopy, which utilizes technology or gadgets that would lift the anterior abdominal wall. So, however, this gasless laparoscopy has the following disadvantages. Basically, it cannot be used when we have anterior abdominal adhesions and bowel distension, and sometimes the instruments are cumbersome because they are large and occupies the space for maneuvering. Now for our principles of port positioning. So position on the port is critical in determining the reach and the working angles of our instrument. So compared with the open surgery, where we have a 360 degrees freedom of range of motion, with minimally invasive surgery or laparoscopic surgery, we have limited motion as shown in the figure. With this limited motion, we have to do do with what we have. So there are different factors that we have to consider. First is the angles of manipulations or angles that that would determine our port placement. We have the azimuth angle, the manipulation angle, and the elevation angles. So the manipulation angle is the angle between the two working ports. Usually it is an ideal manipulation angle would be 45 to 60 degrees. And then we also have the azimuth angle, which is the angle between one of our instrument in relation to the scope. So it is equal to 30 degrees. And the elevation angle would be the angle between the instrument and the horizontal plane, or the plane of the patient. And the ideal angle would be 60 degrees as well. So the drawbacks of incorrect port positioning, aside from limitation of your range of motion, there is so-called the swording effect, or wherein the instruments would be impeding the movement of the instrument within the abdominal cavity. So when when we talk about the port positioning, first is we have to decide the target that we want to operate on. Would it be located in the pelvic area, or in the right iliac fossa for the appendectomy or cecal pathology, or are you going to operate on the right upper quadrant for cholecystectomy, and so on and so forth. So first, you decide the target, and then secondly is you have to know the terrain, or the location that you want to work on. So with this aspect, usually we follow the concept of baseball diamond concept of port positioning. So the home base would be the placement of your camera, and then the first base would be the working port. The target would serve as the second base, and the working port would serve as the third base. So that's the concept of baseball diamond concept. So once you have decided your terrain, then you have to be knowledgeable of your instruments, or the weapons that you're going to use. Usually the length of our adult lap instrument ranges to 36 centimeters, and for pediatrics usually it's 28 centimeters. With this knowledge, we know that at least half or two-thirds of our instrument would be inside the abdominal cavity for it to be functionable. So at least an 18 centimeter to 20 centimeter arc should be drawn. That would be the placement of your working ports. So once you have decided on the placement, then we can lay down your battle plan for at this time. So you should be able to practice the concept of triangulation. So this is used to facilitate smooth instrument manipulation and adequate visualization. With triangulation, the target organ is about 15 to 20 centimeters from the camera port, and then the working ports are placed some 18 to 24 centimeter arc around the target organ, and at least 5 to 7 centimeters on either side of the camera. So with this, you will achieve our manipulation angle. We also have the concept of sectorization, wherein the optical trocar is placed as one of the lateral ports, and usually it is utilized in appendectomy. So the 10 millimeter trocar is placed on the umbilical region as the optical trocar, and the two other trocars or working trocars are placed below the trocar laterally. So this concept is applicable once the plan has been laid, then you can execute your action. You can achieve the manipulation angle of your instrument, which is optimal at 60 degrees. And this concept is not only applicable to the abdomen, but also to the same principle can be applied in thoracoscopic surgeries. So the following are the suggested position for port in various surgeries for diagnostic flap, bilateral hernia repair, for cholecystectomies, as well as for appendectomies, and so on and so forth. Our next topic is on ergonomics. So ergonomics, um, we all agree with we all agree on the advantage of laparoscopic surgeries. So it has good cosmesis, lesser tissue injury, less cause of pain, and then lower complications and early return to work. So as we all know, these are benefits for our patients. So how about the surgeon? So how does the procedure affect us as the um, person doing the procedure? So it is said that laparoscopic procedure is safe or less pain for patient, but is more demanding for the surgeon. So how is this so? Because we all know that we have the limited range of motion in doing the procedures, and then the chronic use of our instrument would cause pain along its pressure points. And most often we would assume difficult positions or poor postures during the procedures, and it takes its toll on the surgeon that conducts the procedure. So we have the so-called surgeon morbidity syndrome in laparoscopic surgery, wherein the overuse syndromes, nerve compressions, poor port instrument position, and equipment issues such as problems with hand grips and visual chain, as well as improper posture and difficult position, all takes its toll on the patient, on the surgeon, causing difficulties like carpal tunnel syndrome, tenosynovitis, chronic pain of the neck and the back, as well as headache and eye strain, not only physically, but could also cause mental exhaustion, poor performance, and irritability. So it takes its toll on the surgeon. It could affect not only his performance of the surgery itself, but it could also affect his personal life and on other things that he performs on. So that's why the concept of ergonomics is important for us. So the word ergonomics comes from the word ergon, meaning work, and nomoi, or meaning natural law. So it places the surgeon in an environment to perform in the most favorable setting. So this is the science of refining the design of products to optimize them for human use. So better understanding and application of ergonomics not only optimizes productivity intraoperatively, but would make the life of the surgeon more comfortable, as well as decreasing the incidence of injuries. So the concept of ergonomics is based on ideal posture, with a proper height of the operating table, proper position of the visual display, proper positioning of the foot switches, and selection of an instrument, as well as the laparoscopic surgical technique itself and the team performance in laparoscopic surgery. So the goal is to have the ideal postures, techniques, and others, so that we will have a safe procedure and efficient procedure, minimizing the injury to both the patient as well as the surgeon performing the procedure. So we want to achieve the ideal posture where the body is placed in the natural or normal position, relaxed position. So for the posture, the ideal height of the operating table is between 64 centimeters to 77 centimeters above the floor level. So it should be at the level of the pubis, where the operating table should be adjusted so that the laparoscopic instruments are slightly below the surgeon's elbows. And the ideal position for the visual display should be about 15 degrees below horizontal line of sight, and the monitor is in front of the patient, of the surgeon, so that the neck is not bent or twist during the procedure. So this could be brought about by adjustable monitor, tables, and support platform that would facilitate positioning. And for the hand instrument, so in selecting the hand instrument, it should enable the surgeon to keep both wrists at neutral position, meaning unbent position. It should permit the surgeon to keep both arms at the side and avoid pressure points on the hands, and allows the surgeon to apply power grip hand position as well as precision grips of manipulation. So for the hand instrument, there have been some instrument grip modification to facilitate that. So to decrease fatigue and enable power grip, it's either you modify how you handle your instrument as shown in the figure, or you can customize the grip to facilitate or to decrease fatigue during handling. So these are the important features of laparoscopic instruments. Next is the ideal port positioning. So we have already discussed this earlier. The proper positioning to achieve the manipulation angle and the placement of a telescope at middle for working middle of working instruments. And then next is the operating room and team positioning. So the ideal position of surgeon and the team and instrument. Usually we place the surgeon is ideally facing the target organ and the monitor in front. So there could be two ways: the American technique wherein the surgeon is on the side lateral to the patient, or the French technique wherein the patient is between the legs of the patient. And this is made it should also be made sure that the instruments and the significant personals are nearby and readily available during the procedure. And the foot switch should also be accessible to the comfortably to the foot of the surgeon. So the team, not only the surgeon, but the team is in ideal posture as well, including the assist. Because as we all know, that lap surgery is a team endeavor, and we should consider the safety of not only the surgeon as well as the assist and the rest of the team. So the ergonomics not only speaks about the materials and the equipments, but also the lighting that we utilized during the operation. So the ideal light should be ambient light, which would be darker, that would facilitate or help you visualize the monitor much clearly. So that would enhance the view of your monitor, and thereby causing less eye strain. For the instrumentation, so laparoscopic instrumentation has three main components: the image production, pneumoperitoneum, and the laparoscopic instruments. So we have already discussed optical devices and equipments for maintaining domain previously, as well as instrument for access and operative instruments. The energy sources and tissue approximation would be discussed later on. For this part, I would be discussing to you the miscellaneous or other instruments that we use during laparoscopic surgery. So first, we have the suction and irrigation probes. These are essential also during laparoscopic procedure since it helps maintain a clear operative field. We have the suction irrigator or the Nezat Dorsey suction tips. So some instruments have incorporated the suction irrigation in the probes of their instruments. Next is the tissue morcellator, which is used to reduce the size of the resected specimen. This is often used when we have huge specimen. However, it would render the pathologic examination difficult due to the destroyed anatomy. Then we also have the organ extraction devices. These are preloaded specimen retrieval pouches composed of strong materials that could prevent leaks and of infectious materials and cancer specimen. And then when there is no way for us to go in, lap surgeons will always find a way. So we have the space creators. which is used to create working spaces in region where there is no natural cavity, such as totally extraperitoneal hernia surgery, wherein the balloon dissector is used in inserted into the in place and inflated with air or saline, and can safely dissect and create access and working space during surgery. And then we have the, as mentioned earlier, the laparolift and abdolift, which is used mainly on gasless laparoscopy. So with this, I end my presentation. Thank you, and have a blessed evening. Hello, sir.
Yeah, we're done.
Yes,
Alex?
sir.
Alex, who's moderating? Anyway,
I have a question. Dr. Benefe, I have a question for Charlie.
Yes, sir.
Charlie, you mentioned earlier with regards to creating a semicircular arc around an area where, a semicircular arc where in the center of the radius or the arc is the target organ.
Yes, sir. Yes, sir.
So as you showed in your lecture, it's around 10 to 15 centimeters. The radius should be around 10 to 15 centimeters away from the target organ. Am I right?
That is for the pediatrics, sir. That is arranged, sir, for pediatrics, or smaller body size. But in other books, sir, it states 18 to 24 centimeters, sir.
Okay, it's 18 to
slide.
20, minimum of around 8 centimeters to around 20 centimeters.
Yes,
We
sir.
can say that probably, right?
Yes, sir.
So, the next, can you just clarify with the group with regards to after the first trocar, after creating that arc, where will you place the next trocars for you to achieve ergonomic and the proper distancing of trocar so that your instruments will not, as we say in the Filipino vernacular, will not do some sword fighting with each other, or they will not cross each other, or it will not be very difficult for the surgeon to do the surgery.
Based from my reading, sir, it should be placed 5 to 7 centimeters on either side of the camera. So that's the recommendation, sir.
Okay, thank you. Or,
yes.
the next trocar should create at least, 8 centimeters away from the other trocar. It would create an acute angle pertaining to the arc. Am I right? Tama ba yung concept? Is the concept right?
Yes, sir. Yes, sir. At least 60 degrees, sir, yung manipulation angle na we want to achieve, sir.
That's the 60 degree or less than the, it's an acute angle.
Yes, sir. Yes, sir.
That would, it creates an acute angle with the arc.
Yes, sir. Thank you, sir.
Any other questions from? Anyway, if you don't have any other questions from the lecture of Charlie, can we go on the second lecture from our fellow? The next lecture is from Kevin Apeles. Kevin is our fellow in Rizal Medical. Kevin.
Good evening, sir. Okay, I'll be sharing my slides. Okay, so good evening, everyone. Thank you to our international speakers for gracing this teleconference. Um, the topic I have for tonight comprises the basics of laparoscopy, including lap dissection and tissue approximation. I will be giving an overview on these and some innovations that will be discussed as well. So again, I am Kevin Apeles. I am the MIS Fellow of Rizal Medical Center. So here are my objectives, and my sources are presented here. I don't have any disclosures. So a variety of mechanisms have been used to divide tissue and enable homeostasis. They all involve some form of physical energy being applied to the appropriate tissue. The ideal dissection technique requires a modality that can accomplish meticulous dissection, meticulous hemostasis, and will be tissue productive without causing any inadvertent tissue damage. In reality, there is no single ideal dissecting technique that we can use for the entire minimal access surgery. The available modalities for dissection include your blunt dissection, your sharp dissection, electrosurgery. I will be touching on it, although this will be discussed further in depth next week or next week. And ultrasonic dissection, electrothermal bipolar, and we'll be touching on argon dissection as well. So blunt dissection is a process of separating tissues using Gasper, scissors, sledges, or even your suction tips. I hope the video will play. Two scissors may be used. You can use scissor points to separate by spreading the jaw. You can use your inactive suction cannula as well, or the heel of your inactive electrosurgical hook, or a fledgel. In the video, we can appreciate blunt dissection using a Maryland Gasper, and the operator is dissecting the potential space between the cystic duct and the cystic artery. So methods involve distraction, separation, teasing, and wiping. Tissue stripping and tissue distraction are other safe and effective forms of blunt dissection. The problem with this is there is insignificant hemostatic capability of blunt dissection without the use of elective surgery. Sharp dissection is one of the most frequent methods in laparoscopic surgery. It offers the benefits of being cheap, safe, and precise. I'll be showing you a video on how it's done. Sharp dissection is inexpensive, it's safe in safe hands, and it's operator determined precise action. However, in this video, as you can see, there are some movements wherein the operator is using electrosurgery with scissors. You can pierce this tissue with those blades and then open it, which helps obtain a good plane of dissection. The problem with this also, without the use of electrosurgery, it is not hemostatic. In this part of the video, you can see that the scissors is being used to, although again with electrosurgery, but some aspects you can see that the scissors is being used to dissect a potential plane in the mesentery. So electrosurgery, this is just a quick overview of it. Refers to the cutting and coagulation of tissue using high-frequency electrical current. Electrical current is created by the movement of electrons, and voltage is the force that causes this movement. The electrosurgical units, or the ESUs, will convert your wall outlet around 50 to 60 hertz to 500,000 hertz, so as not to cause nerve and muscle damage, or nerve and muscle stimulation. The possible effects of applying electrical current include fulguration, desiccation, and vaporization. Electrosurgery can be performed either using a monopolar or bipolar instrument. The main difference is the pathway of the current, which will be discussed later on. You can use cutting or coagulation mode. In cutting mode, your ESU generates a continuous unmodulated low voltage current. The cutting mode will result in more rapid tissue heating than the coagulation mode. In coagulation mode, the ESU generates an interrupted or modulated high frequency voltage current dispersed over a large surface area. This results in coagulation, which is dehydration, a dehydration effect rather than a vaporization. So dehydration is not as effective as vaporization for cutting tissue, but it is more effective for sealing blood vessels. So let's move on to ultrasonic dissection. Ultrasonic surgical dissection allows coagulation and cutting with less instrument traffic and less smoke and no electrical current. It makes use of mechanical energy at 55,000 vibrations per second, and it disrupts the hydrogen bonds and forms a coagulum. The temperature by the harmonics by your ultrasonic device is lower than your electrosurgical unit. It's around 100 degrees lower, therefore resulting to less collateral damage, less tissue necrosis, and less smoke, which I guess is important during this time of the pandemic. So, okay. Let's focus on the video above. Ultrasonic dissectors are two types. Low power, which cleaves water containing tissues by cavitations, leaving organized structures with low water content intact. As you can see in the video above, this is a CUSA. It's an ultrasonic dissector wherein it dissects the liver parenchyma, leaving your bile ducts and your blood vessels intact. As opposed to the video below, here, the ultrasonic shears, your harmonic scalpel, for example, or your sonicision, is ideal for dividing and simultaneously sealing small and medium vessels by tamponade and heat. However, larger vessels need to be clipped. You can use this to around 5 millimeters of a vessel. Another lap dissector that we can use is your electrothermal bipolar tissue device. This allows the surgeon to improve vessel sealing with minimal thermal spread to the surrounding tissue. One example is the ligature device, which allows for hemostasis by vessel compression and obliteration through the emission of bipolar energy. So I have a video of it. It delivers the exact amount of energy needed to seal it permanently, and vessel sealing is reported to up to around 7 millimeters. This technique is different from a conventional coagulation method that achieve vessel sealing by tissue carbonization. In fact, the heat generated from the bipolar energy determines the fusion of collagen and elastin in the walls of the vessels with the creation of a permanent sealed zone. The sealed zone, which you can see, shows a translucent appearance that is easy to recognize. Furthermore, this sealing system has a minimal thermal effect on tissues, so minimal heat, meaning minimal possible injury to surrounding tissue, and minimal smoke. Next is an argon device. The argon beam is used in conjunction with monopolar electrosurgery to produce fulguration of superficial coagulation. So I have a video here. Argon plasma coagulation is a non-contact monopolar technique. It was initially used for endoscopic applications back in the 1990s. The probe of the delivery catheter contains a tungsten electrode through which a high-frequency electric current is delivered to the target tissue using ionized argon. This results in coagulation of the target tissue. Treated tissue demonstrates 3 T zones: the desiccation zone, the coagulation zone, and the devitalized zone. Let's show in the video how it's used. In this part, you can see that the argon beam device is used to dissect the gallbladder from the liver bed. In this part of the video, you can see that without contact, dissection can be achieved. It's superficial. It doesn't penetrate too much through the tissues. There is noted to be less smoke and lesser depth of tissue damage. So let's now move on to the bulk of the matter, laparoscopic tissue approximation. So we'll be discussing laparoscopic suturing, an auto suture device. We'll be showing a clip of it, your pre-tied knot, an extracorporeal knot, your how to create an extracorporeal knot also, and your endostaplers. So let's start off with laparoscopic suturing. The proficiency with laparoscopic suturing is of crucial importance. It not only allows the performance of a wide range of complex operative scenarios, but also is an essential skill required for dealing with possible intraoperative complications. Laparoscopic suturing techniques can be classified as laparoscopic suturing techniques can be classified as either in intracorporeal or extracorporeal. Let's first focus intracorporeal suturing. So you must choose first the correct suture length, and you must always use a curved needle and grasp the proximal third of the needle. This video that I'll be showing is a technique of laparoscopic suturing. It's Chaucer technique. So I'll try to voice over the video. So the needle is introduced and grasped 1/3 of the way. The tissue is penetrated. You grasp it with your left hand and you perform laparoscopic curtsy. And then you create a short tag. You make sure that the needle is properly placed. You create a loop. You grasp the tag with your right hand and you lock the knot. Once again, you do it again from below and then you lock the knot 5 o'clock and 11 o'clock. Create a third knot 7 o'clock and 1 o'clock. I'll be presenting another one. This is the other technique. It's the Sabo technique. The main difference with your Rosser technique is in Sabo, you change hands. So I'll voice over the video again. So the needle is introduced with your left hand, and then you grasp the needle 1/3 of the way, penetrate the tissue. You grasp the tip of the needle with your non-dominant left hand. You perform laparoscopic curtsy so as not to injure the tissue. You grasp it again with your right hand, and you create a C loop with your left hand, making sure to create a short tag. The right hand is holding the needle. And now you extend and supinate it so as to create a loop. There you go. Another loop. Okay. Short tag is grasp, and the knot is locked. 7 o'clock and 1 o'clock. You change hands. This is the main difference. Transfer it to your left hand, and you create a reverse C. And then make a loop and grasp the short tag again and lock it. 5 o'clock, 11 o'clock. You create a third knot by creating another C. Create a loop by extending and supinating your right hand, and then grasp the short tail and lock it. So again, the main difference with the other technique is that you have to change hands in this technique, the Sabo. So traditional laparoscopic suturing and knot tying requires somehow of a steep learning curve, and it's often the rate limiting step in performing advanced laparoscopic surgical procedures. So it's particularly challenging due to difficulties with tissue handling and needle control while performing the procedure in a two-dimensional plane. So they have offered a device, for example, this one is an auto suture device. Excuse me. This has greatly simplified the process and allows less experienced surgeons to safely and efficiently perform laparoscopic suturing and knot tying. I'll forward the video a bit so as you can see. There. The endostitch and the sail have added advantage of articulation for up to 75 degrees and rotation up to 360 degrees. This enables the surgeon to operate in tight spaces during laparoscopic procedures. So this device makes laparoscopic suturing easier. However, it's not always available. I actually haven't seen one. Okay, so in the video on the right, you can see that the operator created an enterotomy and is now approximating the two bowel loops to create an anastomosis with the stapler. You will then close it using the endo stitch. Okay. Pre-tied loops can be used for any fluid structure, for example, in doing your laparoscopic appendectomy. But for continuous structures, we need to be able to know how to create extracorporeal knots. So this is a pre-tied knot, either your end loop or your surgery tie. This tool allows for easy ligation of the structures with no need of creating your own loop. It is appropriate for the endoscopic ligation of blood vessels and other small tubular structures. Oops, sorry. Create a video. So the loop was drawn up into the metal sleeve, and then once inside the abdomen, the loop is advanced using a push rod. You put your target tissue in between within the loop, and the loop is delivered over the tissue. The loop is then tightened around the tissue by tensioning the long end and applying pressure to the knot by the push rod, causing it to slide, just like this in the video. The knot is locked firmly in place, and the gasper is removed, and the rod is removed. Then cut the tissue. I cut the knot. On no account must endoloops be used to close a perforation in any organ that is not going to be resected and removed, as the tissue included in the endoloop will slough off eventually. Okay, so another option is creating your own knot. Pre-tied knots are expensive and relatively expensive and may not be always available. So as such, extracorporeal knot should be part of the skill set of an adept MIS surgeon. The first laparoscopic sliding knot to be described was the Roder's knot. So in the video on the left, the operator is creating Roder's knot. The formula is 1-3-1. So 1 half hitch, 3 full turns, and a locking half hitch. So in the video on the left, you can see that the surgeon now is locking it with the last half hitch. There you go. Okay. I'll show a video wherein it's shown clearly. So in this video and creation of the Roder's knot, the left hand suture is longer than the right. You create a half hitch as seen in this video. Then you create 3 full turns. 1, 2, and third one. And then the locking knot is half hitch as shown here. This is the last half hitch. Lock it in place. Keep it snug. There, that's a Roder's knot. Okay. Another one is the Tay-side knot. So in the Tay-side knot, it's the same as the Roder's knot in the sense that the left suture is longer than the right. You create a half hitch first, and then on the long-standing suture, you create 3 or 4 full turns. There. After the full turns, you insert it in the second loop, and then on the third loop. Keep it snug. That's the Tay-side knot. The last extracorporeal suture that I'll be presenting is your Meltzer knot. It's a modification of your Roder's knot. It's quite bigger, that's why it's easier to push with your knot pusher, and it's easier to push with your knot pusher, your Maryland. So again, the Roder's knot formula is 1-3-1. For Meltzer, it's 2-3-2. Oops, sorry. So I'll just there. So 2 half hitches, 1 second half hitch, and then you create 3 full turns. 1, 2, and third one, and then you create a locking half hitch, two half hitches. So I hope we do it there. Okay. So one half hitch and another one. That's for your melter knot. So as I mentioned, it will create a bigger knot than your roder's knot, which is easier to push. So part of your tissue approximation or your clip. Clipping is also is cheap and readily available. Disposable preloaded clip applicators are available in 5 and 10 millimeter diameters. Titanium is the most widely used metal clip in minimal access surgery because it rarely reacts with the human body, and after a few weeks, it's covered by fibrous tissue. So in this video, although this is not a metal clip, the operator is using a Hemolock clip. The Hemolock clip is a non-absorbable polymer clip with lock engagement feature, which allows for more security there. You can see. And you can also appreciate the dumbbell effect after, let's see, after this. So the surgeon will place the clip, and after you lock the clip, you can appreciate the dumbbell effect. So we need to beware of cross slipping and also to avoid slipping fatty pedicles. So now let's move on to endo staplers. Different staplers and staples and cartridges are available to adapt to any type of surgical procedure. So depending on the form of the stapler, they can be linear, curved, or circular. These staplers can be used to cut tissue, vessels, or even create anastomosis. We all know about this. I'll just show you wherein after creating an enterotomy, the operator will place the one bowel loop on one arm of the endostapler and another on the other arm to create an anastomosis. Yeah. The enterotomy can also be closed with another stapler. And these staplers can pass through any staple line without risk of leakage. So I'll be discussing some innovations in minimal access surgery, minimally invasive surgery, and instruments that are noted to be innovations. I'll also be giving an overview of hand-assisted laparoscopic surgery and single-incision laparoscopic surgery. So hand-assisted laparoscopic surgery was first described in the 1990s. A variety of techniques allows the surgeon to insert the gloved non-dominant hand into the abdomen to assist in retraction. And the technique is used less commonly nowadays, however. In the past decade, it remains useful for procedures for laparoscopic donor nephrectomy and other hepatobiliary surgical procedures. So this is a video. In this video, on the left, we can see that a sieve appliance is used to maintain pneumoperitoneum there, while the operated hand is inserted through a small incision into the abdomen. As in standard laparoscopic surgery, the surgeon visualizes the operative field with a view monitor, but in addition, has the advantage of a human hand at the operative site here. You can see. So in this part, you can see that dissection is facilitated by the non-dominant hand. And suturing can be done with a laparoscopic instrument and your hand that is inserted. In the second video, one advantage is that because one hand is inside the abdomen, it's easier to control bleeding blood vessels. You can pinch it with your hand inside the abdomen. Okay. Let's now move on to single incision laparoscopic surgery. So So SILS was first described in general surgery in 1997 to perform laparoscopic cholecystectomies and appendectomies. There's a resurgence of it in the early 2000s because there were technical improvements in the available instruments. These are the articulating instruments and the adjusted laparoscopes. So the image on the upper left shows a single port device inserted in the umbilicus, and the image on the left lower shows how the instruments are inserted in the hand position using this port. So this is a short, let's just move through the video. It's a bilateral tap done single port. So after access and creation of the space, the single port device is inserted. There is the single port device. There's a still picture of it there. And all instruments pass through it. So the main advantage of SILS over standard laparoscopic surgery is in cosmesis, with surgery becoming essentially scarless if the incision is hidden within the umbilicus. Only one incision is required, so the risk of potential complications like your port-site hernias, hematomas, and wound infection is reduced. Existing evidence at the moment suggests that SILS is similar to standard laparoscopic surgery in terms of complication rates, in terms of completion rates, and post-operative pain score. However, the duration of SILS is longer, dependent on the operator. So let's now move on to innovations and advances in MI dissection that I want to share with you. So this is a percutaneous device. Here. So Percuvance by Teleflex is a percutaneous microlaparoscopic platform that combines a reusable handle with a low-profile instrument shaft and various 5mm tips. So the main benefit of the system is that includes smaller incision, around 2mm incision, and the reduced need for ports or trocars during your laparoscopic procedures. It's indicated for the means to penetrate tissue, and it's used to grasp, to manipulate, to cut, and to cauterize. So smaller incisions again. Another one that I would like to mention is your articulating devices. So on the lower left is FlexLec, and on the lower right is your artificial articulating laparoscopic device. So I'll just show a quick video of it. So the FlexDex is a minimally invasive surgical tool that provides surgeon with additional degrees of motion. So as what was discussed by Dr. Cabangal in the previous lecture, there is minimal movement where using your laparoscopic stick. So with the FlexDex device, as you can see here, that the end or the tip would move just like the wrist of the surgeon. So the instrument articulates the end effector, and the surgeon simply bends the wrist, rotating the infinity handle. Will spin the tool an equal number of degrees, and the squeezable trigger on the handle opens and closes the effector, allowing full multi-axis wrist control. The FlexDex system has been called the handheld robotic platform, which is, of course, because it's just a handheld device, it's cheaper than your robot. The next one is your artisanal device. It's almost the same as your FlexDex. It's designed to provide the user with fully articulating wristed motion during laparoscopic surgery. Here you can see there, the double joint structure of the arsenal end effector allows the instrument to move with 300 degrees of freedom, just like having your hand inside. Again, it's like a movement of the robot, but with a handheld device. Now, so what is the robot that I've been mentioning? The robotic systems are comprehensive master-slave surgical robots. Here, this is a video from Da Vinci. The camera arm contains dual cameras, and the image generated is a 2D 3D image. The master console consists of an image processing computer that generates a true 3D dimensional image. The instruments are cable driven and provide 7 degrees of freedom. This system displays its 3-dimensional image above the hands of the surgeon, so as to give the surgeon the illusion that the surgeon is operating inside the surgical field. So it has applications in bariatric, upper GI, hernia, urology, and gynecology. Okay. So this, a few more. This is my last two innovations. The one on the left is your Hand X. It's an articulating power device. Here, this image. So it's a single-use handheld powered laparoscopic device and offers technical benefits of robotic surgery. As you can see, the tip of the Hand X will also articulate and move just like a robotic arm. There. The last one, this one is also from Da Vinci. This is the Da Vinci single port system, which includes 3 multi-jointed wristed instruments. And the first Da Vinci fully wristed 3D HD camera that fits in a 2.5 cm cannula. So as you can see in the video, everything that you need, the 3 arms of the robot and the camera, fits in a small cannula. The surgeon will control the fully articulating instruments in the camera on the Da Vinci system via a same console as was presented a while ago. So this is my last slide for innovation. So in summary, there is no single ideal technique in laparoscopic surgery. In laparoscopic dissection, we must familiarize ourselves with the many methods and principles of elective surgery and dissection. MIS surgeons must be adept at the basic skills such as laparoscopic suturing. Laparoscopic suturing, both extracorporeal and intracorporeal, is an important skill that must be part of the laparoscopic arsenal. Innovations are coming in, but we must consider the basics first and be proficient in the basic methods as well. Also, being adept in the basic and advanced skills in laparoscopy is an essential step. So there are no shortcuts. So that's my last slide for my presentation. Thank you for your time.
Thank you, Kevin.
Yes.
Okay, for our next speaker, may we call on Dr. Sujit to talk to us about COVID-19 guidelines in surgery. Dr. Sujit?
Yeah, hi. Yeah, give me a second. Let me share the screen.
Sorry, stop share.
Are you able to see my screen?
We can see Sujit.
Yes.
Your
Yeah,
screen.
Sujit. Clear. Thank you. Go ahead, Sujit.
You can see the screen or you cannot see the screen?
Yeah, we can see. Can you already play?
Oh,
your
perfect.
slideshow?
Yeah.
Perfect. Thank you.
Yeah. Okay. So I'm going to talk about safety of the healthcare workers, so surgeons as well as nursing during this period. So this is basically what we have done. This is based on WHO guidelines as well as our Ministry of Health guidelines. So this is according to Ministry of Health. So basically, they have categorized quite nicely what are the personal protective equipment to be used in the inpatient facilities. So if you talk about the wards, they have nicely categorized what healthcare workers, which means doctors and nurses, should be using. So cleaners, visitors, they have categorized nicely. So those who are providing direct care to COVID-19 patients, medical masks, gloves, gowns, so basically full PPE. If anybody is doing aerosol generating procedures, such as say intubation or bedside scope, we must use N95 or even PAPR. Outpatient facilities, so basically this is the surgical clinics, so healthcare workers who are coming into physical examination of patients with respiratory symptoms. So medical mask, so this can be a N95, so And we try not to see these patients in our clinics. We see them in the isolation wards. So we usually screen our patients well before they come into our clinic. So this doesn't really apply to our clinics currently. So I'm just going through the WHO guidelines, what they have given. So examination of patients without respiratory symptoms, they say the standard PPE and hand hygiene and all that. So I will skip this part. So this is about triage, laboratory services, administrative areas. So in summary, everybody must wear a face mask during this period in NUH as well as AH, and all the healthcare institutions in Singapore is a must to wear a face mask at least in all the clinical areas. Then comes to mask management. I'm sure you all know about this, but I will just highlight a couple of small things that may be important. So it's important to remove the mask using the appropriate technique. So usually we shouldn't touch the front of the mask and you remove it from the back. This also applies to the N95 respirators. So, and after removal or whenever you use a mask and if you touch inadvertently the front of the mask, you should cleanse your hand thoroughly. Irrespectively, any mask you wear, you must follow strict hand hygiene after removing the mask, also before wearing the mask as well. So replace the mask as soon as they become damp with a new clean dry mask. So these are important things that sometimes we don't really. Ministry of Health decided basically on what are the essential services to carry out and what are the non-essential services to carry out. So essential services for surgical services include trauma, burns, and nearly all the emergency surgical services. And what are those non-essential services? So conditions like gallstone disease, hernia without symptoms, even with symptoms we have delayed now. So, and pediatric patients. So these are considered non-essential patients to come into hospital during this period. So there has been very clear guidelines at national level with regards to this, what are essential and what are non-essential. So based on this, we came up with some guidelines to follow at our clinic. So SOC is basically our clinics. So contact and droplet precautions for all patients by all staff, which means face mask and gloves. Contact and droplet precautions is different from precautions for diseases that spread through aerosols. So contact precautions and droplet precautions, basically, as I mentioned, is wearing a face mask at all clinical locations and using gloves during examination. And all cases that comes to our clinics, we have screened once 3 days before and once 1 day before. So twice they're getting screened, asking them about respiratory symptoms, any fever, and travel history. So if they have any of these, their appointments are either delayed or if it's urgent with their complaints, we will ask them to come to emergency department. And for suspected cases of COVID-19, so which means including those patients who answer yes for any of the screening questions that I mentioned, we ask them to come to emergency if it's urgent. And we go to emergency, we wear the full PPE and enter in N95 and goggles or face shield, then we examine them there. And we don't mix our so-called clean community, which is in the clinics, with the likely hot zones, which are emergency department and isolation wards. So then confirmed cases of COVID-19, we follow the same thing as for suspected cases. So we have not brought these patients into our clinics. And we go down to either the emergency department or we go down to the isolation wards and isolate them, and we see them in a negative pressure room. We have reduced our workload in clinic about 30 to 40%. We put a max number for the first visits and review visits. And we also started providing teleconsultation for patients who doesn't really require physical examination, say for patients who are after follow-up after scopes, and those patients who are after their first visit review, after hernia repair or gallbladder surgery or certain cancer surgeries, that we don't really need to physically touch them and do a physical examination. Then we minimize staff attending to patients at all stages and locations. So this is basically what we have followed at our clinic. So a similar plan was followed at NUHS level, which is our cluster, which includes Alexandra Hospital, where I'm working now, in NUH, and also we have another hospital called Nteng Phong. So recommendations that we have followed for endoscopy. Since endoscopy, especially OGD, there's a higher risk of generation of aerosols. Therefore, we use full personal protective equipment, which we use the gown as well as face shield, N95, and for all patients, we did this. We have minimized staff attending to patients at all stages and locations. So we only limited to one procedurist, one assisting nurse, and one circulating nurse for these procedures. We only perform emergency cases and also urgent elective cases, such as if a patient comes with a PR bleeding with loss of weight, etc., and if it's a higher risk that this patient may be having a cancer. So we have considered this as urgent cases, then we have done these cases following the guidelines that we have given. So we have few endo rooms, but we limit the use to one because we had to get our nurses and our assistants to be utilized in other areas like ICUs and pandemic wards to cater for the increasing number of patients. What do we do in OT? Again, only emergency cases and urgent elective cases should be done. So what are these urgent elective cases? For when we started our COVID-19 exercise, which means when the DOSCON changed from yellow to orange, we have listed about 20 cases of hernia to be done within the next 6 weeks when we first started. So I think out of this, only one patient came in with severe pain and incarceration. So we had to do this as an emergency case. So other than that, the other hernia patients actually did not require emergency repair, or we did not have to do them as urgent cases. So this gives an idea the impact of a pandemic on delaying cases like hernia, which are not necessarily considered as urgent or urgent cases to be done as electively. However, we had cases where patients with previous past stones, past gallstones into the bile duct, a couple of these patients actually came back with recurrent abnormalities in the LFTs or jaundice. So we had to do these patients to clear. So then again, minimize staff attending to patients at all stages, all locations. So basically we had only one surgeon. We didn't really use an assistant. If really needed, we use only one assistant. So one assistant, one scrub nurse, and one circulating nurse. So we minimize the staff within the theater. Confirmed cases of COVID-19, we use a negative pressure OT room. The laminar flow is not adequate for a positive COVID case. And we use PAPR for this kind of positive cases or even suspected cases. So next is what kind of protective equipment that we used for patients who are not confirmed COVID or who are not suspected of COVID-19. Anesthetists, they use N95, goggles, face shield during the time of intubation. All the other times they had to wear a mask, and all the nurses wear a mask. So nurses and surgeons, I'm talking here about non-COVID positive patients, and all they have been tested for COVID, and the swab has been negative twice. So surgeons, we were wearing surgical masks, not necessarily N95. And if we are doing laparoscopic cases, we had the option of wearing an N95, even if it is a non-COVID positive patient. So where possible, during intubation and extubation, we stayed away. We were in the preparation room and not inside the theater with the patient and the anesthetist. So N95 and goggles to be used for all head and neck surgeries, even though this is a negative COVID negative case. So thyroid surgeries, we use N95 and goggles, and or face shield. We actually started using ultra low. So basically, we have usually we have filters. So filters for smoke evacuation. So ultra low particulate filter has been used where we can use it basically for during smoke evacuation, as well as to release the pneumoperitoneum in laparoscopic cases. So what did we do for positive cases or suspected cases? Everybody was wearing N95 goggles and PAPR, and we made it mandatory to use UPA filter when using surgical energy diathermy, as well as releasing the pneumoperitoneum, and endoscopic cases as well. I think that's all I have. So now we have come to the stages of restarting services. We have this thing called circuit breaker period in Singapore, which ends on the 1st of June. So we are going to start services in a staged manner. So we have 3 phases of starting. So phase 1 will last for 1 month. So we will start increasing the clinic workload about another 10 to 20%. And we will start doing those urgent cases that we have postponed, and still giving the priority to cater for the ICUs as well as the pandemic wards. Then the second phase will be 3 to 6 months. So within this period, we will start to build up our workload back again, and then start doing more elective cases. So that's all I got to say. I'm happy to answer any questions.
Thank you, Sujit. Alex? Hello.
Yeah.
Yeah. Thank you, Sujit.
Yeah,
Okay, thank you. Thank you.
We'll just continue with our lecture to
Sure.
the topic of fundamental use of energy. May we call on Dr. Rakesh?
Yeah.
Rakesh?
Yeah. Just a moment. So good evening, all of you. I am presenting the fundamental use of surgical energy. So I will start with brief introduction regarding the use of energy in the surgery. It goes to old ages at the time of Hippocrates, when he is quoted the heat cure when everything fails. The basic primitive type of electrical surgical unit was first invented by, we can see in the picture, Dr. Bowie, which stand his name, and it was used by neurosurgeon Dr. Cushing. So there are few questions. I mean, we use this kind of energy device every day in our OR. So do we consider yourself an energy expert, and can we assemble the favorite device which we use in our theater? And have you have ever any associated with any injury from any energy device? Or have you ever used any energy device without prior training or reading package insert? So to answer this question, so we can see this slide. This is the young lady which undergone a small skin mole excision, and this is the result. She sustained the surgical flame burn, and this is the result what she got. Then this is the on the left side of the slide, we can see the bowel injury. So this patient underwent the gynecological surgery. She sustained the electrical surgical injury and had colonic perforation. And this is the result after the 4 laparotomy. If we see the data of US, near about 2 million of lap surgeries is performed every year. And the data of bowel injury is 1 to 2 per thousand cases. So major public attention was drawn when the famous congressman died in with the laparoscopic cholecystectomy. He was operated and discharged on the second day, and again operated on the fifth day and died on the seventh day. So this is the data of near about more than 300,000 laparoscopic surgery performed, and it shows the incidence of bowel injury is overall injury, bowel injury is 1%. Unrecognized bowel injury is near about one third. I mean, one in every third bowel, in every three bowel injury, one is bowel injury, and overall mortality is 3%. And if unrecognized, it can lead to mortality up to 8%. So we need to understand a few of the fundamental principles of the fuse, because hundreds of OR fire occur annually. There are about 40,000 patients burned by faulty electrosurgical device annually, and up to 70% of these burn are undetected at the time of injury. And in 1990, near about 600 million US dollar claim was produced by this kind of injury. And the Emergency Care Research Institute has quoted the top 10 health technology hazards into 2012, this surgical burn and fire. So the SAGES conducted one questionnaire from the 48 leader, and what they found, only 60% able to answer this questionnaire correctly. 31% didn't know how to correctly handle the fire on patient. 31 patient couldn't identify the device least likely to interfere with the pacemaker. 13% of them didn't know the thermal injury can extend beyond the jaw of bipolar instrument. And this is again one survey conducted by American College of Surgeons among the 500 surgeons. And what they found, 18% had personal experience with electrosurgical complication, and 54% of them know the surgeon who had experienced complication. And most common complication involve were small bowel, colon, biliary tract, and ureter. Again, this is the data put up by the SAGES among the 400 surgeons. And what they found, there are near about 50% of the surgeons they surveyed that doesn't have any amount of training. And this is again a survey of 102 surgeons, and regarding the where did you receive most of your knowledge of these devices, and 42% are, answer that they received this kind of knowledge from the industry representative. So let's face it, would you go under the surgery if you know your surgeon doesn't know or train on the device which is used in your surgery? The answer will be no. So these are few objectives of my presentation. Like we should, at the end of this talk, we should know regarding very basic about the radio frequency elective surgery, then basic function of this ESU unit, then difference between monopolar and bipolar, and the radio frequency energy, what is the effect it's called in the cell and tissue, and identify the difference range of temperature on the cell and tissue, and few complications. So we should able, because in OR we call give us the cautery. So we need to differentiate what is cautery and what is electrosurgery. So cautery is basically a direct current through a high resistance metallic conductor, and it is essentially application of heat on the burning of the tissue. Whereas comparison electrosurgery is the high frequency alternating current on the living tissue, and the energy is produced within the cell that destroy the tissues. So this is the example of cautery. We can see the, if we burn our finger with the match, so that is what we call cautery. Electrosurgery is the alternating current which is used, and in every household, in like in our house, we have electric current which is supply either 50 or 60 cycle per second. And we know at that frequency we got electrocuted because nerve and muscle start activation. So at the range of 100 kilohertz, this nerve and muscle stimulation cease. So the electrosurgery can be performed safely beyond the 100 kilohertz. So in this slide, we can see the as the wavelength decreases and the frequency increases, we can perform the electrosurgery. So these are the few benefits of the radio frequency. The tissue effect which it gives is the controllable and more predictable, and it doesn't polarize the nerve and the muscle. So how does the radio frequency electrosurgery work? It caused the when we applied the this electrosurgery to onto the our patient. So this is the basically electromagnetic energy, which in the cells converted into the kinetic energy. This kinetic energy then converted into the thermal energy, and this thermal energy give the various effect which we desired. That is vaporization, means cutting, then coagulation in form of desiccation and coagulation, and again one form of coagulation, that is fulguration. Slightly a detail about the how does it work in the cell. So when we apply the alternating current on the patient body, the we know our every cell has positive and negative electron. So these intracellular ion try to oscillate 10,000, 100, even 1,000 times in the cells. So that oscillation produce the friction inside the cell, and that elevate the temperature. We will see the effect of temperature. So in this slide, we can see our normal temperature is near about 37 degrees centigrade. And if we raise temperature between the 50 to 60 degrees centigrade, the cell death occur within 1 to 6 minutes. It take time. But when we raise the temperature beyond 60 up to 90, the cell death occur instantly without any time, and it produces two effects, that is desiccation and coagulation, which we discuss in the further slide. And if we raise temperature above 100, so that is the boiling point, and at that point of the time, cell burst and rupture. So this is the effect of temperature of 60 to 90 degrees centigrade. When we apply that temperature, the cell membrane rupture, water came out, and the protein form a coagulum. This white coagulum we can see. But and when next procedure, next when this temperature cool down, that protein try to take its original shape, but it couldn't able to come into the original shape. That lead to deformation, and that entangle with the collagen strands, and that what we see as a desiccation process, desiccation and coagulation process. Next is the electrosurgical unit. So this we see every day in our OR. So we need to know at least three of its function. So first, on the left side, we can see first is we connect with our source, that is the 60 hertz. That it convert the 60 hertz into the radio frequency output, that is 500 kilohertz. Second function is what we see in the electrosurgical unit is we can change the output of this current. I mean, we put 30 or beyond that. Then next is adjust the Then third point, third function of it is control of the duty cycle. We will see everything. So when we push the button of 30, so what it does do? So in cutting, so if we add the oscilloscope with the cutting waveform, so this is the waveform we got. Is the high current, voltage is low, and it formed the continuous current. In comparison to coagulation, the current here is low, interrupted, but the voltage is very high. The duty cycle of this coagulation is near just about 6%. So 94% of the time this waveform is off. Then what is blend? So next press is the blend. So blend is the mixture of cut and coagulate. Its voltage is slightly higher than cutting. And other thing we need to understand is blend 1, blend 2, blend 3. That is the time of the duty cycle, means 50%, blend 1 is 50% on, blend 2 is 40% on, time is on, blend 3 is 25% on. Then these are the effect they produce, means vaporization or cutting, then desiccation and fulguration. So in this we can see the direct touch with the tissue should be, when we are doing cutting, direct touch with the tissue should be avoided to achieve the maximum effect. Then next is the desiccation and coagulation. For the formation of sound vessel seal, the coptic coagulation is required. I mean, we need to cop these two wall, and that can be performed with very low voltage continuous output, which we can see in the next slide. So in this slide on the left side, we can see when the high voltage current is passed, there is a formation of desiccated tissue, which next time act as an insulator. So current in the deeper tissue could not be passed. So the desired coagulation is less. In comparison, if we can see the slide on the right side of our screen. So coagulation, in this we use very low voltage current. So that current goes very deeply, and coagulation is better in this kind of waveform. Again, this is the same slide, low power cutting mode used to seal the vessel, because when we use high voltage, high power current, I mean like in coagulation, the voltage is very high. That lead to formation of, after desiccation, it lead to formation of carbon, because it break the tissue into the elemental carbon. Then after, even if we apply more energy, that elemental carbon can also break down into the elemental sugar, and that can lead to caramelization. So that effect lead to poor vessel sealing. So other factor, when we use these kind of things, we need to consider the other comorbid factor like liver cirrhosis, patient on chronic steroid, atherosclerotic vessel, malnourished patient, patient with systemic infection, diabetic and collagen vascular disease. So these energies can also cause the lateral thermal spread. Like in this slide, we can see if we use the lower voltage, the lateral thermal spread is very less. And if we use the higher voltage, like in coagulation, the lateral thermal spread is very high. So in this slide, we can see the temperatures between the two jaws is near about 300 centigrade, that can spread to lateral tissue. And suppose in this slide, we can see if we use 100 watt temperature, 100 watt power for 3 seconds, so it can burn near about 6 mm of surface tissue. Other form of energy we use is the fulguration, is the high voltage modulated current, and in this we don't touch the surface area, so that large surface area can be covered with for the coagulation, like liver bed or raw oozing surface area in the peritoneum. So by smart smart use of our electrode, we can also modify the effect. Like in this slide oscilloscope, we can see the low voltage current can be used, like it's a cutting mode, can be used for even the coagulation also. Like with the edge of the blade on the right, on the left side, it can be used as a cutting mode, and if you use the side of the blade, it can be used as a coagulation mode. That can reduce the lateral thermal damage because the voltage here is very low. Then I will discuss regarding the monopolar and bipolar. So all these radio frequency surgeries are bipolar. What the difference is basically the location of the second electrode. So this is a very basic about the monopolar system. It has a circuit, generator, active electrode, patient, and patient return electrode. So in this slide, we can see all this. Then next is bipolar. So bipolar, the active output and patient return electrode function are both are at the site of the surgery. Current pathway is the confined to the tissue grasp between these grasper, and return electrode should not be applied for the bipolar procedure. It's a very basic about the bipolar. And initially we used to heard like we need to ground the patient with the electrode. So nowadays these systems are not available because the risk of injury are very high. So all these return electrodes is incorporated in the generator in the newer modalities of our system. So when we use the bipolar, what the action required is desiccation and protein coagulation. But when we overcompress, so in this right side, we can see the if we overcompress the tissue, the desired action may not happen because these two electrode, when we compress, these two electrode can touch together. So what are the benefits of the bipolar? It doesn't require the dispersive electrode, which can be the one of the causative factor for causing the burn. Then the capacitance is not an issue, which we'll discuss later on. Then energy primarily stays between the jaw, and it requires usually the less voltage and current. The second speaker discussed very few about the voltage and current also. Then but there are limitation of traditional bipolar, which is that is the continuous uninterrupted delivery of the energy. Surgeon control the delivery of the energy, and there is no feedback mechanism to determine, and PI stop tissue very poorly, and coagulation is often incomplete. To overcome this, so there are newer modalities has been designed to give us a feedback mechanism, and it has a better consistent hemostatic mechanism, less thermal spread, less plum formation, which is the need of these days, less tissue carbonization and sticking, and it can seal up to the 7 mm vessel. So a very basic, I won't go into the detail of that, but very basic about this mechanism are they are smart generator technology, and they act as a near real-time impedance feedback for the delivery devices. And the total energy required is very less, and they have auto regulation at the output jaw. So when the vessel seal, it give audio feedback and stop working. So these are the few devices available in the market like LigaSure, InSeal, and Thunderbeat, and every day new things are coming in the market. So this slide shows the few side effects of these devices like monopolar and bipolar. Like thermal spread with most of them are near about same, and direct coupling, capacitive coupling, alternative site injury is can occur with the monopolar, not with other devices. Direct thermal extension can occur with the monopolar. Current leaking through the cord can occur with the monopolar and advanced bipolar. So next few slides, I will discuss few of the complications which can occur with this electrosurgical unit which we use. So first and foremost is the direct coupling. Direct coupling is when we activate our electrode and it is touching the any other instrument. It can happen in the open surgery also, as we can see in the right side of the slide, and even the laparoscopic surgery, like if we are doing in this picture, we can see the colonic surgery is performed, and this active our grasper is touching the telescope, and that can act as a direct coupler and can cause the injury to the colon. Insulation failure. So insulation failure is another cause of injury during the surgery. So this is a very small data, a paper published, and it shows the it uh, studied the 226 laparoscopic instrument, and it found there, like in reusable instrument, the chances of insulation failure is near about 19%, and disposable instrument, the chance, even in the disposable one, the chances of insulation failure is 3%. And most of these insulation failure occur in the distal part of instrument. Then next is capacitive coupling. So capacitive coupling is like if we in the left side of the slide, we can see the instrument and the trocar. So every instrument act as a, when we through a current through a instrument, it create a electromagnetic field around that. So that electromagnetic field goes to trocar, and it pass to skin surfaces in skin and muscle. But when we add like we suppose if we use a hybrid cannula, so that diffusion of electromagnetic field doesn't occur, so it conserve the energy into the trocar. And if that trocar touches with the bowel, that can lead to energy, that can lead to injury of the surrounding structure. Like in this picture we can see like if we wrap a cord around the hemostat, which is very common practices in our setup, so that can act as a capacitor and can cause the skin injury. Another form of capacitive coupling is like we use this model in the seals. So it can also, because instrument can act as a capacitor and can injure the bowel. Another form of injury is like when we are active electrode injury or inadvertent activation, like we are looking on the paddle and we are operating on the screen. So that can happen. Other thing like pacemaker also, we need to be very careful when we are using this radio frequency. We should not use this kind of modalities with the pacemaker. Other kind of injury can happen with these are remote heating, like in this picture we can see a gynecological surgery is performed and ovary and fimbria are touching the bowel. So in remote kind of the cases can lead to bowel injuries, because all the environment around that tissues are air, water and electrolytes can disperse the energy and cause the injury. Even the CBD also, if you use large amount of coagulation energy around that area, that can disperse, because all these structure contain the fluid. So even the current can disperse around the CBD also, later on can present as a CBD stricture. Other kind of injury is patient return electrode. That is again one of the avoidable injury. We should choose our padding area very carefully, and the surface area of this should be at least 100 square centimeter, and it should be divided. And the burn caused by this surface, this can be depend upon the area applied to that. Other kind of injury is the like sometimes we got the burn with the our electrodes. So that is due to burn if we inadvertently become a part of the circuit, And definitely the surgical smoke, viral DNA, bacteria, carcinogens, irritant are also known to present in the electrosurgical smoke. So at the end, the recommendations to prevent all this complication is to basically understand the basic fundamental of energy devices, some kind of physics which we use in our OR. And to prevent this injury, we need to inspect insulation very carefully. We need to use lowest possible power setting. We need to use the lowest voltage also. To I mean, even the cut can perform a very big amount of coagulation also. Use a brief intermittent activation rather than prolonged activation. Don't activate in the open circuit. Don't activate in the close proximity or direct contact with any other instrument. Use bipolar electrosurgery whenever appropriate, and select an all metal cannula system as the safest choice, rather than using the hybrid one. And these newer modalities which are coming in the our OR can give us a better feedback mechanism when we are operating. Thank you.
Thank you, Rakesh. Uh, any questions for the last three lectures? We'll entertain the questions.
Sir, may I ask something po?
Yes.
Thank you, sir. So, thank you, Dr. Rakesh, for a very comprehensive lecture, and Dr. Sujit. My question was for Dr. Sujit. First, thank you for sharing your experience in your country. My question, sir, Dr. Sujit, is you mentioned that you are preparing to do elective cases in your institution in the next coming weeks. Do you, sir, do routine testing like RT-PCR for your incoming elective cases prior to scheduling them for OR?
Okay, we are starting after 1st of June. So that's where our so-called circuit breaker will end. So we are not going to do routine PCR testing for healthy patients. But if they have respiratory symptoms or if they have any history of fever within the last 2 weeks, then I think we will have to do testing or even postpone the surgery further. Does that answer your question? Yeah.
Yes, sir. Thank you, Dr. Sujit.
Yeah. Yeah.
There's a question here from Dr. Joel Silahay. Is there any new evidence regarding aerosolization of COVID virus particles when using energy devices?
Okay, it's known that any energy you use in a COVID, if it's a COVID positive patients, any energy, any surgical energy, be it diathermy, bipolar, ultrasonic, all these can generate aerosols. So that's why we suggest that, and also according to even our ELSA guidelines that's published recently, try to minimize use of unnecessary use of energy devices and use smoke evacuators with any form of surgical energy that creates smoke. And yes, please wear N95 for patients who are suspected or even for normal patients if you think there will be a need to use extensive energy.
Well, to answer also that question, we all know that viruses like Hep B and the like would come into your plume. But then again, there's still no evidence that your COVID virus would go with the smoke, with the plume. We don't have any data yet regarding that one. But then again, because of knowing that the infection would cause a lot of morbidity and mortality, then we go for a more we want the healthcare workers during the surgery to be safe, and that's the reason why we'd always look on putting ULPA filters, smoke evacuators, and everything. So that's the reason why. But then again, even having said that, we still don't have any data regarding that one. Even the societies that initially, right after the pandemic, the start of the pandemic, because of the things that we know of, that's why laparoscopy was somehow stopped, at the initial start of the pandemic. But there's no definite data yet. Any
Dr.
other?
Sujit, Dr. Allen.
So, Professor Enel, are you doing the laparoscopic surgery these days or just open one?
Come again?
Are you doing the laparoscopic surgery also or just open one?
I'm still doing laparoscopic surgery, primarily because of the hospital that I'm working with and doing surgery in the province, our own private hospital. We have two different entry point for patients that are suspect COVID. And our hospital, by the way, does not admit COVID patients initially. But then again, because of how we were able to, the physical setup of the operating rooms, it's separated between the DR and the surgery. The one that we have, the MIS room that we're doing surgery for laparoscopy and non-COVID patients, is also a negative pressure room. Hence, with that one, we made the DR rooms as the COVID room and the MIS room as the non-COVID room. So there's a separation, distinct separation from patients. We know that we can separate all of them, so we're still doing our elective procedures in that hospital. But then again, in other hospitals where entry and exit of patients are the same, we defer doing even open surgery, elective open surgery on these hospitals. It's always the way we do it, the way we approach it is depending on the number of COVID patients that the hospital has. If you have a high number of COVID patients or even suspect COVID patients, we defer the elective surgeries. Just last week, just to recap, for all those who were present last week, we were lucky that we have a foreign speaker coming from China. He's the the assistant director of Shenzhen Hospital. It's a 3,000 bed hospital. It's a non-COVID hospital. The nice thing about China and Hong Kong is they were able to separate the patients from the hospitals from a non-COVID hospital and a COVID hospital. So with them, if you look on Hong Kong and even China, elective surgeries are still going on even at the height of the pandemic because they were able to separate the high risk or the COVID patients and the non-COVID ones. I think that's how the ideal setting for on how to deal with patients. Any comments, any suggestions, or any from the group? Hello. The nice thing about the UMIST group is for the three main hospitals, actually even including Amang Rodriguez, Fatima, Amang Rodriguez, JBL, SPMC, we're all government hospitals. And the nice thing, the advantage and we have advantages and disadvantages. The disadvantage is we cannot refuse patients, and there's a DOH circular that came out right after right after the start of the pandemic that government hospitals are converted now to have as COVID wards, right? In BAT MC, I think Dr. Palinas can explain later. The whole surgery department, actually, the whole surgical ward were converted to COVID ward. So these are the things that you need to look at and things to consider if you're going to do your elective surgery or not. Dr. Pal?
Yeah, I would like to ask the two institutions, namely Rizal Medical and Quirino, if they have already started doing elective surgeries, and if they had started, when do they plan also to proceed to doing laparoscopic surgeries?
Yes, Joel. Uh, Joel? Uh, unmute yourself, Joel, please.
Sir, sorry. We at Carina, sir, we have not yet started our elective surgeries, and although we plan to soon, we were actually drafting already proposals to be submitted to the hospital management on how we were going to go about starting our elective surgeries. Sadly, that has taken a backseat because of the fears of the second wave. So we do not know yet if we are going to push through with our plans for elective surgery. And regarding the laparoscopic surgery, sir, I think we will start those also as soon as we start our electives. We will not distinguish from open and lap. We will also do our laparoscopic surgeries once we start our electives.
Rizal?
Good evening, everybody.
With our
For
surgery. And regarding the laparoscopic surgery, sir, I think we will start those also as
Magic, you know. I think it's coming from the YouTube. Anyway, Ray, yeah. Please continue, Ray.
as for Rizal, we haven't scheduled any electives yet, but for this week, we already opened our outpatient department. We were supposed to have a 10-hour head and neck case today, but we just had to cancel it and reschedule it for next week. But I think we're slowly opening up. I think the idea of us holding off electives or laparoscopic surgery during the quarantine or the lockdown period is for the institution, the department, the hospital, be able to prepare its system, its the community or the people around or the people involved with surgery. So we are able to better, or we are better equipped to protect ourselves and actually protect the patients and be able still to deliver quality surgery for our constituents. So I think uh, uh, we had to buy time to be able to prepare so that we will be able to still deliver the kind of quality care that we are able to deliver to our patients non-COVID times or pre-COVID time or pre-COVID era or pre-pandemic.
Actually, Alan, from our side, I think um, during the Zoom conference this earlier, it was mentioned by the director of Amang Rodriguez that there is a DOH directive uh, directing all hospitals, DOH hospitals, to postpone indefinitely their elective surgeries. Having said that, we in the Department of Surgery at BAT MC has already conducted a series of meetings with the department, with the operating with our committee, with the infectious disease consultant. And initially, when the directive has been lifted, we plan to open our OPD so that we could start screening and admitting initially cancer patients, because these are the kind of patients which really cannot wait. They cannot wait for the COVID crisis to be solved. And we all know that this will linger on for maybe until the end of the year, or perhaps even next year. So we have already set our plans in case the directive has been lifted. And in fact, we plan to start our OPD already on May 26. So by the time the order of prohibiting the government hospitals from scheduling elective cases has been lifted, our patients will be ready to be admitted and be scheduled for elective surgeries. Maybe open surgeries, and specifically for cancer patients.
I can see Noel Evangelista. Kuya, Dr. Noel Evangelista is the director of a private hospital in north of Manila. What have you done, Kuya, in your hospital?
Good evening, everyone. Yeah, last Monday, we we actually opened our clinics and medical arts building. However, we controlled the number of patients that a doctor can see to a maximum of only 10 per doctor. And we continued on with the we have this so-called quick check stations where we interview all incoming patients and ask them to fill out a health declaration card. Well, for of course, to ask for their travel history, occupation, contacts, if they come from a cluster of a place where there are reported cases of COVID cases. Well, we are very strict, and we practice this, of course, the physical distancing and all the precautionary measures. We still are not accepting or taking in elective cases. We still do just the emergency cases, and we will try to open up to urgent cases. Of course, we always try to follow the PALES guidelines. So that's about it. Thank you.
Thank you, Kuya. Anyway, the question actually came from Rakesh. How about you, Rakesh? Rakesh is also working in a government university hospital. It's a huge complex. It's more than, I think it's, the size of the complex is bigger than UP Diliman. And the complex is quite nice. It's like colder than Baguio. Rakesh, how do you do it in your place?
In Nepal, the situation is not quite worst. I mean, my hospital is level 3 COVID hospital. So all the quarantine facility, all the positive cases we don't keep. The patient which need the super specialties kind of the care, which we are getting for the. So we differentiated COVID hospital and non-COVID hospital in our complex. So all the patient with the positive COVID and suspected goes to COVID, and the non-COVID come to our general practice. But as our staff, all our doctors, nurses, and all our management are utilized in that COVID hospital, so amount of services, if we see the surgical services, we reduce the surgical services just for the emergency and elective oncological services. We don't do any kind of cold cases, and even the laparoscopy we have not started. A lot of papers are coming regarding the, I mean, laparoscopic is safe with all the precautionary measure which has come with all of you, but till now we are not started. But yes, emergency and oncological surgery we are continuing. And even in last 2 months, if we see that kind of surgery, we have performed near about 200 surgery, like emergency and oncological surgery, but it is all open surgeries. But even,
You,
and other thing is, in the first month we are not doing the we haven't done the COVID test. But now for the all the emergency cases, we are start doing the uh, PCR in the patient which can wait, like oncological surgeries, we can advise for PCR testing. Even in the emergency also, the patient who can wait for 12 hours, we are doing the PCR testing. But at the end, is basically the precautionary measure. Whenever we perform the surgery, like even in the open, we use full protective gears for that.
thank you, Rakesh. Rakesh, there's actually a question for you at the
Yeah,
chat.
I am typing her answer. The answer, I mean, the it's a good question. As we know, the heat kills.
Let me repeat the question first, for the benefit of those who haven't read the question. The question for Rakesh is, sir, you mentioned instantaneous cell death occurs at 60, 90, and 100 degrees due to the alternating polarity of the current as fast as 50,000 hertz, thereby causing vaporization of biological tissues. Wouldn't this theoretically also destroy viruses such as COVID? Uh, so if it's a 50,000 hertz per second, right? So this is the ultrasonic device, if I'm not mistaken, Rakesh?
So it destroyed the virus at the tissue where we applied. But as the data are coming, like even most of our tissue, like peritoneal fluid, also having the virus. All the GI tracts also having the virus. And so we don't know, I mean, the place where we apply our because we don't apply the energy devices in the whole plane. We dissect the tissue, we use the peritoneal fluid. So yes, if you ask for the tissue where we apply the energy, it kill the virus. But when we dissect the tissue, it like in the laparoscopic or even in the open, when we dissect the tissue or play with the peritoneal fluid or GI tract, even in the urology also, they have, I mean, urine also, the virus is there, so that can lead to spread. So answer for this question is yes, temperature kills the virus, but during the surgery we don't apply the energy devices to everywhere, and we do the dissection, we manipulate the field, so that can lead to spread of the viruses, because it is present everywhere, starting from the peritoneal fluid, GI tract, all the urological, even in the urological system also. And if you see the presentation, the first ELSA presentation that on for the COVID, I mean, they have stopped all the thoracic surgeries, like this transhiatal oesophageectomy, and even the transthoracic oesophageectomy. This kind of the surgery they have stopped because of high mortality, high morbidity, and we are opening the thorax.
Thank you, Rakesh. Any other comments from the group? There's a question for Zamboanga Medical Center and SPMC with regards to the elective surgery. I think Dr. Cirillo is here, Dr. Alex Cirillo. Dr. Alex Cirillo is the past chair of the Department of Surgery of the Zamboanga Medical Center. Dr. Cirillo, the boss of Charlie.
Yes, Alan. Good evening. Can you hear me?
Yes, sir. We can hear you, sir.
Yeah, good. Yeah, good evening, Alan. Congratulations for this webinar. I enjoyed it. As far as Zamboanga City Medical Center, we have not yet opened our OPD, so we don't have elective operations yet. But our setup is we have a separate COVID operating room and a non-COVID operating room. The COVID operating room is in a separate building at the OPD, which was converted to COVID patient, and the operating room, one operating room, is located at the fourth floor. The non-COVID is located at the old operating room. So we're doing emergency and semi-urgent operations for non-COVID. Okay, but no elective yet. We're still waiting for the memo from DOH to start the elective operation, because as Alex Tocayo mentioned, there was an administrative order suspending all elective operations, including private operations in government hospitals since the start of the pandemic. So we're waiting for the lifting or the rescinding of that memo. And in fact, we have not started yet the OPD. But in most private hospitals, I think they're already doing elective operation, because most of the COVID patients now are admitted in the government hospital. Yeah, thank you.
Thank you, sir. Thank you, Dr. Cirillo. Anyone from SPMC? I think I saw Geoffrey Betanyo. Who else is here? From SPMC, Southern Philippines.
Hello, sir. Yes, sir. Good evening,
Yes,
sir.
Hi, Geoffrey. Mangabi, bye.
Yes, sir. Mangabi, sir. Sir, in SPMC, we have not yet started our elective surgeries, although we also have a separate OR rooms for COVID patients and non-COVID patients. So for the non-COVID, we cater only the urgent cases, sir, and the emergency cases only, sir.
Thank you, Geoffrey. Oh, by the way, Dr. Cirillo, this is not a webinar. This is our weekly conference for the UMIST. But we took advantage of the Zoom platform and inviting every week our foreign friends to join us and give us more insights on how we deal with diseases. So weekly, we'll have our own conferences. We will be happy to invite everyone again to join us. Next week, we'll inform everyone the date, because next week we'll be starting the mid-year convention, if I'm not mistaken. Tama ba yan? So we'll do that one. We'll give you a update on that one. There's a comment from Dr. Fuentes on YouTube. Dr. Fuentes is on YouTube stream. His comment is, cancer patients cannot wait, but on the other hand, they are the ones at greater risk of poor outcomes if they contract the infection perioperatively. I think it's right. Any comments with what Dr. Joboy has said?
Alan Sujit here. Sorry, so for cancer patients, hello?
Yes, Sujit.
Yeah. So for cancer patients, it depends on what cancer. So we have stopped operating on thyroid cancers, but colorectal cancers, hepatobiliary cancers,
And so basically the principle is that if the patient will deteriorate and if the patient will deteriorate if we wait for more than 4 weeks, are divided into one group. If the patient will deteriorate even further, if we wait for 2 weeks, are divided into another group. So this is how we have differentiated. So thyroid cancers, basically, they can wait a bit. So we have not done thyroid cases much. But colorectal, we have proceeded, and HPV, we have proceeded. Yeah, so this is what we took as a guidance, and this was given by our MOH as well.
Very true. Just say, I think let's get this last question from Dr. Reyes, Elmer Reyes from Batangas Medical Center. Having said that using electrocautery promotes higher risk, though not yet proven, open surgery might be more risky. Any thoughts? I think we can ask Sujit and who took up the electrocautery. I think Sujit and Rakesh, right? So COVID and energy.
Yeah, so the thing is this. So as you mentioned, there is no concrete data to prove that the virus has been isolated from the smoke equator. But virus has been isolated from all sorts of body fluids. So to be careful, to be on the safe side, that's why we use all the PAPR and PAPR for positive cases and full PPE for suspected cases or even normal cases where the aerosol generation can be a risk, like in head and neck cases. So again, yes, the definite evidence is not there that using cautery definitely gives rise to spread of the virus to healthcare workers, but there's a potential risk. So even we use ultrasonic energy device, as mentioned in the comment. So what can happen is there is a thermal spread. So within the area of thermal spread, the temperature differs. So ultrasonic vibration give rise to aerosol. So not all aerosols will be heated up to 200 degrees or more. So this is where the suspicion, this is where the issue is. So we cannot be guaranteed that we will not get it. Therefore, because the disease has a higher risk of morbidity as well as risk of mortality, it's better to be careful.
Thank you, Sujit. Rakesh, do you want to add anything with the question?
I think Sujit has answered very correctly. I mean the evidence are coming every day. Everything, the things are changing. So first and foremost is first try to save your, try to be a very protective and try to use full protective equipments whenever you operate, rather than believing which is not producing which is less or more producing the virus in the environment. The ultimate is you need to use the productive equipment, because datas are changing, the science is changing every day in these 3 or 4 months.
Thank you, Rakesh. Any other comments from the floor before I think it's almost 9 o'clock. So we have 3 hours of a very fruitful discussion and lectures from the 4 lecturers. We would like to congratulate the 2 fellows. And of course, we would like to thank Rakesh Gupta from Nepal, and of course, Sujit Wijaratne from Singapore, NUH Singapore and Alexandra Hospital. Any other comments or from the group? Anyway, we would like to acknowledge also the presence of Dr. Ramon Badillo, the chairman of Amang Rodriguez. Hi, sir. Thank you for joining us. Also, the hospitals from JBL, JB Lingad, Paulino Garcia, SPMC of Davao, Zamboanga Medical Center. Ano pa ba? Please forgive me if I...
So, Sir
ano pa-
Medtronic, sir.
what other hospitals? Anyway, if I forgot the name of the hospital, please forgive me. And of course, we would like to welcome Linda Su and Wen. They joined us actually for this conference. It's going to be a weekly conference. We'll try to limit the next conferences to 1 or 2 topics that would really interest you. Maybe next time we would have some foreign guests, foreign lecturers, and maybe 1 or 2 presentations from our fellows. The fellows would be rotating initially from the 3 hospitals, and hopefully we'll be able to include all the other hospitals who would be joining the linkage of UMIST. You're more than welcome to join us. Last words from the big boss, the 3 chairman of the 3 training institutions. I'll start off with Ray. Ray.
Okay, thank you, Dr. Benafe. Thank you, Kuya Allen. So it has been a fruitful night, and I hope you all learned a lot from this teleconference series. You expect more from the UMIST group. So see you again next week. Thank you very much for attending, even though it's a little bit late.
Dr. Joel Silayo from Quirino.
Yes, sir. Again, thank you very much. Congratulations to everyone, and thank you to our foreign speakers for imparting their knowledge to us, and for a very great discussion. So congratulations to everyone, and congratulations to Dr. Benafe.
Dr. Palines.
Yeah. Thank you, everyone. Thank you, Dr. Rakesh and Dr. Sanjit, for joining our weekly conference. And of course, congratulations to our 2 presenters, Charlie and Kevin, for an excellent presentation. See you all next week.
Okay, thank you everyone. Maraming salamat. I think the end, the message would always be, our goal is to provide safe, optimal, efficient care that should be proportionate with the available manpower and infrastructure resources. And of course, we should always, always weigh the benefit of surgery. We have to look on what's the benefit if we conservatize the patient, what are the complications that would arise as a result of your delaying your intervention. And of course, we'd always think of patient safety and patient success. And of course, right now, because of the pandemic, we'd always think of the safety also of the healthcare workers. With that, we would like to thank everyone, especially our 2 foreign guests. Sujit, Jaratne, thank you so much. Rakesh,
Thank you, Prof. Thank you
for joining us. I hope
Thank you.
you can join us again. And congratulations to Kevin and Charlie for a very nice presentation. To everyone, maraming salamat po. Good night.
Good night. Thank you. Congratulations.
Bye.
Good night, sir. Thank you.
Good night.
Pause ko lang yung streaming, boss.
Off na.
Ay, sir, Sir Alex.
Tapos siguro, mag-isipin ko muna yung
Sa YouTube, Arlene. Off mo muna yung YouTube kasi